So that's really interesting, right? Because with all the hype around ketamine for pain, and then people kind of like don't like morphine as much, we can see when you actually evaluate it, there's no statistically significant difference or even clinically significant difference here.
But if we delve into that, so there is no clinical or statistical significant difference in reducing their pain scores between morphine and ketamine in this study.
Yeah.
So they always use the word ketamine is non-inferior to morphine. So that means it's not worse than morphine, but it's also not better in this aspect.
We're going to talk about the PACKMaN trial to start today. The study just came out 1 week ago, so hot off the press. And I think it's incredibly applicable to kind of what's going on in Ontario now, given the fact that we're soon to be using ketamine for pain.
Yeah, it's quite timely and it's relevant. And everyone loves to love ketamine. And this is actually a really good trial. Like really good. And it's generalizable to paramedics in Ontario, which is nice.
Absolutely. Exactly. I guess today we'll go through a critical appraisal of this study, see like what was good about it, what was maybe not that good about it, and how we can apply it in our practice.
Sure. So do you mind giving them a brief overview what a critical appraisal is? Because
absolutely. So the most, brief definition is just that instead of looking at a study and just reading the abstract and seeing what the authors concluded themselves, you would read through the paper, look at all the different aspects of, the sample size, the inclusion-exclusion criteria, the methodology, and see if that is like a high enough quality study to inform your practice. One of the most important things to do is to make sure that it, assesses this intervention in a patient population that's similar to yours, and also in a clinical practice context that's similar to yours, right? Mm-hmm. So like when we talk about intubation stuff, which we've nerded out on quite a bit, if you were to look at like OR research, it doesn't necessarily translate well to the pre-hospital environment, to the paramedic environment, right? So that's kind of what we're going to do with this today. This study was conducted in the UK. So I guess we'll start with saying, what's the research question, right? Mm-hmm. So what they were looking to do is to see if ketamine is superior to morphine for the treatment of traumatic pain. Mm-hmm. So their inclusion criteria was anyone over 16 years old with pain of over or equal to 7 out of 10 from trauma. So they excluded patients that were pregnant. They excluded patients that were unable to articulate pain severity, obviously because it would just affect the study outcomes, right? Lack of capacity, and also patients who received parenteral analgesia prior to randomization. So we wanted to make sure that these medications were the first ones being given to see their effectiveness. So this study was done in 2 ambulance services in the UK. Now, what's awesome about this is they were ALS paramedics that have similar education, similar scopes of practice to advanced care paramedics in Ontario right now. So that definitely increases the applicability, right? Also, the study protocol very closely mimicked our protocols for these medications. So they could give a max of 20 milligrams of morphine and a max of 30 milligrams of ketamine for pain. So what are your thoughts on that for the applicability?
Yeah, it's relevant. It's nice to know. And I like it because we probably know, just speculating, ketamine use will go up because it's new. And everyone loves to love ketamine, but is it superior? And this study addresses that research question. So right away, it's a randomized controlled trial, and it's pretty rigorous. Like it's a good trial. And it does have just some generalizability to our practice in Ontario. Does that mean a blanket statement? It's going to entirely shape our practice? No. It's just one more piece of evidence on top of all the evidence that the physicians look at. So 7 out of 10 greater pain, so severe pain. We don't have any specification for what type of pain there is in our medical directives. They did that for a reason because the numerical stars are it's not very robust, I would say, right? But we should reserve probably an opiate and ketamine for more severe type pain. Morphine is the gold standard for analgesia and narcotics. So it's interesting, how does ketamine compare to it? The one difference is our max ketamine dose, unless you patch for more for IV for adults, is 20 milligrams. So they give 30. So there's that range of a non-dissociated dose.
Right. Yeah. So I guess they'd be giving a larger dose, but still within that kind of range, right? So it's like they also advocated for titrating to effect. Now, what's really cool about this study is the paramedics are actually blinded. So the paramedics and the patients were blinded to which drug they were administered. So they gave just a vial of medication that was pre-diluted, pre-prepared to the same like 10 mLs. And then it had a barcode on it that they scanned to later on be able to unblind in the analysis to see which drug the patient actually got. And what's actually quite interesting is they did a test of blinding effectiveness after to see if the paramedics could guess which drug they gave the patient, and they couldn't. It was no better than random chance. So they couldn't tell whether they were giving morphine or ketamine just based on the effects and the efficacy, I should say. So that's really interesting.
Pretty good.
Yeah,
It's a good trial.
That makes it, like you said, extremely rigorous, right? And then so with research, we always talk about ethics, right? So it's very important in clinical research that an ethics board approve all studies utilizing data from human subjects. And it's important to note the study went through a rigorous ethics approval process, especially since it was an interventional trial. They were trying this like medication and also using that blinding and randomization. So it's definitely a good tick box to look at when we're going through studies as well.
Why is it good to blind the paramedics and also the researchers?
That's a really good question. So blinding helps negate some kind of biases that you can find. So if the paramedics know, oh, today is a morphine day, they might affect their practice based on that. Or today's a ketamine day, maybe I'll affect my practice based on that. On the patient side, if you tell the patient, well, I'm giving you morphine versus I'm giving you this cool new fancy drug that might be even more effective, that kind of primes them, right? So it can start affecting placebo effects and biases like that. And then it's unblinded in the analysis. So even the research team themselves, other than like the research paramedics that are actually looking at these charts, they don't know what patients are getting, which is really great.
I like that. Very rigorous once again. It mitigates most of the blinds. You cannot erase bias from it, but that's pretty good.
Absolutely. So another really key part of this trial, any sort of research trial that we're looking at, is sample size. So we know that randomized controlled trials often have more difficulty reaching large sample size than retrospective or prospective cohort studies, because they're that much more expensive. They're a lot more complicated to run. You can't just look at 10 years of data, have a giant pool of patients, right? You have to actually enroll these patients. And what that means is these trials are often at higher risk of type 2 error, which is a false negative. So if I'm trying to look at the difference between two groups and the groups are really small, I might not be able to find a statistically significant difference between the two, even if the drug might actually be causing a difference in the population, right?
So why is that bad? Why is a false negative bad?
Well, it just means that like your the reliability of your research will be decreased by that, because you want your research to reflect the external world, the real world. So if you have 10 patients in each group, you need to have like a 50% improvement in pain scores versus one versus the other in order to reach that statistical significance, right? So it's what tells us that our results are not likely due to random chance. That's kind of what that p-value of less than 0.05 that you see in all your research. That really just means that we are fairly confident that these results are not due to random variation. There's a real difference in the system.
So what is 0.05 right now?
There's like a 5% chance that these events or that these differences are due to random variation. So it's never perfect. No. Some studies are powered to 99%, but you still have that one. So, it's all a probability game, right?
So that means that if you flip it, 95% chance that this is legit.
Yes. And that maps on to kind of the stats we're going to look at, where they use 95% confidence intervals. So we know that the real result, we're 95% confident, exists in these intervals. We'll talk about that. Well, but what's interesting is when your sample size increases, those intervals narrow, your confidence increases. So that's a really kind of good way to look at it. In this study, they did a power calculation prior. So they knew what, sample size they needed in order to actually get that 95% confidence which is really important. We can briefly touch on this. It's really important not to overpower these studies, because then you can have clinically insignificant differences that show up as statistically significant. And as clinicians, we really don't like that either. They determined that they needed 446 patients. And if I'm not mistaken, they got 449. So that's amazing. They got exactly what they needed. Within that sample, we want to look at the demographics of these patients. When we're looking at the demographics of the patients in a study, we want to see if it matches. Like we talked about this earlier, right? Does this match my patient population? And then are there any differences in the baseline clinical characteristics between these two groups that could confound our results? And what's beautiful about randomized controlled trials is they help control for allocation bias. So these groups, actually, if you look at the demographics in the paper, which we'll link to, you can see they're very well balanced groups. They're pretty much identical, which is awesome.
So pretty equal sex, ages, comorbidities, and everything.
Exactly.
Because those can all skew the results and the response to the interview.
Absolutely. Yeah. You can imagine, right? If you had a group that had much more severe injuries, maybe they were older, that could skew your results. And in this case, they're very well balanced.
Yeah, I'm highly impressed with the authors.
Absolutely.
Well, it doesn't mean much I say that, but still impressed.
So the next thing that we want to look at is kind of the statistics that were used, right? So we'll keep this brief because I know that not everyone here wants to learn about advanced stats in research. But we can utilize different statistical tests to determine if the differences between these groups are not due to random variation. That's kind of what we were talking about earlier. And what's really important with this study, a lot of randomized controlled trials just use simple tests that don't correct for any kind of differences in the groups, or covariates is what we'd say. Whereas this one, they used linear regression for their primary outcome. So using a regression model, we're not going to get into the weeds, but it helps control for any differences between the groups to make sure that really what is causing that difference in the like pain score. The difference in pain score here is the drug. There's nothing else in the sample that's kind of contaminating that. It's an important way to do that. So the primary outcome, which we talked about, was determining if ketamine is superior to morphine in proving the difference in pain scores, right? So if a patient had a 9 and now they're at a 6, that's a difference in pain score of 3. So that's kind of what they were measuring, right? And then for that primary outcome, the mean difference for morphine was 3.4, and the mean difference for ketamine was 3.5. Now, some could look at that face value. Oh, there is a difference, but no, it was not statistically significant. So it was
Nor clinically.
not really, right? We wouldn't look at that and say, oh, that makes a big difference in my patients.
Because that's the key thing to take away. Something might be statistically significant, but clinically insignificant.
Absolutely.
So, but both are like negligible.
Exactly. Yeah. So that's really interesting, right? Because with all the hype around ketamine for pain, and then people kind of like don't like morphine as much, we can see when you actually evaluate it, there's no statistically significant difference or even clinically significant difference here.
But if we delve into that, so there is no clinical or statistical significant difference in reducing their pain scores between morphine and ketamine in this study.
Yeah.
So they always use the word ketamine is non-inferior to morphine. So that means it's not worse than morphine, but it's also not better in this aspect.
Yeah, and I think one of the really key parts of this study, which is actually the parts that I found more interesting, was the secondary outcomes, right? So it helps us decide which patient population we want to use this medication, because morphine had higher rates of desaturation and hypotension than the ketamine group, and that was statistically significant as a secondary outcome. However, you have to know that with these studies, they power for the primary outcome. So any other findings are considered exploratory. You have to power a study to look for those outcomes to be sure. In the ketamine group, there was an increased prevalence of behavioral kind of problems. So patients kind of having some more delirium, some more confusion, maybe a little bit more agitation, which is also expected, right? So I think that helps us understand what patient population we might want to use these drugs. The ketamine had more sedation as well. But in terms of long-term outcomes, which they also measured, which is really amazing for the study, there was no difference in rates of chronic pain, and there was no difference in terms of quality of life at 3 and 6 months. That's really key as well, right? Because we know that undertreating pain causes like PTSD and a lot of chronic pain issues like that. But both these drugs, you're serving your patient right.
So let's make that operational because there's so much good wisdom in there.
Yeah.
Is it empirically known we undertreat in pre-hospital setting for pain or overtreat or better on par where we should?
So it used to be quite bad. We definitely used to undertreat quite a bit. There's no doubt about that. And then there was this really, I think, effective campaign within the base hospitals to address that. And I think we're doing it a lot better in terms of just the culture of treating pain and making that a priority, right? And using medications like methoxyfluorine, which is hopefully going to come on board at some point, will allow the PCB scope to address these patients' pain a lot better. But then also, removing kind of these barriers and improving our scope of practice for pain management, which included ketamine is a really good step in that, because then we can treat pain in patients that might be a little bit more hemodynamically unstable.
Right. So the last time I looked at this was a couple of weeks ago, and this isn't like CAMA specific; it's kind of unanimous.
Okay.
I think in the pre-hospital setting, we undertreat 40 to 50%. Whether that's we don't treat at all, the suboptimal dose, maybe not the best medication for them. So it's like those pretty staggering statistics. But again, like you said, the base hospital has done an amazing job. The Ministry of Health and College System has done like we need to treat patients' pain, and the World Health Organization. People may find this funny, but they're like treating pain's a human right.
Yeah.
Like imagine you go for a service and you're just like, I broke my arm. We're like, man, too bad. I don't think that's enough to warrant a Advil and Tylenol. You did well.
Yeah, I think gone are the days of, those ACPs potentially that were kind of priding themselves on the fact that they've, not given narcotics often for pain or things like that, right? We're a lot more liberal with that now. And, the study, the research does support that practice. We're doing, a disservice to patients if we're undertreating their pain, not just in the moment, but long-term. Right?
Yeah. And that goes back to what you said, high risk for chronic pain, depression, PTSD, increased hospitalizations, and all these worse outcomes.
Yeah, exactly. So I think the way that we should leave this, at least, is what kind of patient would you choose ketamine in that's let's say trauma versus morphine? What operational context do you think would serve as a good example for those two?
So this is interesting. I'll do the objective overview, and then I'll do my bias.
Yeah.
And of course, this is all dependent on where you work, your service, base hospital. They all have different perspectives. So the way the medical directives are written, you can technically decide to use ketamine first. Or I work outside of this, it's that we should always combine it with an opiate and try the opiate first, unless they're contraindicated, unless they have opiate use disorder. But I know a lot of the physicians, so it's all dependent on their practice and everything. Right? So honestly, for trauma, my first pick would be fentanyl. But we can get to that, and that's what the study also talked about. Morphine. Morphine's a really good analgesic. It is. It's our gold standard. It's a good analgesic. It does provide good titratable analgesia for the most part, right? We know some people may need higher dosages. I can tell you that 5 milligrams for an average size adult who was pretty healthy and 30 years old, broke their femur, probably won't respond well, right? I always remember the stat that if you give somebody an adult 0.1 milligram per kilogram, so every 80 kilos, you give them 8 milligrams, only half the people will respond to the initial dose. So as soon as you know that, you're like, okay, maybe it's just suboptimal dosing. So there's a lot of nuance in giving analgesics, letting to work, slow pushing it, and letting it peak, because it usually takes around 15 minutes to peak, right? 15, 20 minutes. So that's interesting. So if I was thinking, I know it shouldn't matter, but it is a factor. Are they going to be on offload? How long is my transport time? How fast do I want a drug to work? And how bad is their pain? All dictates my practice. Have they used opiates before recently, right? So that all matters. Ketamine's quicker, generally. Ketamine's good because it generally doesn't drop their blood pressure. It can increase their blood pressure from norepi and epinephrine released from the adrenal medulla. So that's a consideration. We know ketamine is fairly safe at the dosages we give, and we'll hammer in the point. When we're giving these dosages, we're not trying to dissociate them. The higher the dose, or the increased risk of dissociation, comes with more side effects, which are not simple. They're not, we shouldn't just say, man, when we're spasm, man, they may stop breathing for a bit. They may have hypersalivation. It's rare, but it is pretty tremendous side effects. And all the physicians I speak to have seen it. They're like, it's not pretty. So we have to be cognizant of that. But I love the dosages we give with our medical directives in the study because the analgesic dosages are between 0.1 milligrams per kilo to 0.3 milligrams. So for reference for our medical directives, the physicians made it easy at 0.25 milligrams per kilogram for the IV route and 1 milligram per kilogram for the intranasal route, which is a very good, safe, reliable route. So I think for trauma, ketamine's been empirically shown to be beneficial in trauma and burns, especially when you combine it with an opiate like fentanyl. Because we know that multimodal approach is that overall, if I combine an opiate like fentanyl and ketamine, I have two different medications with different classifications and mechanisms that overall provide superior analgesia, and you reduce the amount of opiates needed. So it's that opiate sparing effect. So that's the practice I would try to use, that I would try an opiate like fentanyl for those specific circumstances and top it up with some ketamine to overall reduce the analgesic requirement. Again, it's hard to give broad paintings because it's all contextual. Like Absolutely. It all depends on the patient. Like, what if they have opiate use disorder? What if they're opiate naive? What if they're elderly? Because we know the elderly can be more or can suffer more consequences to get. Right? So it's like, ugh. But overall, I think they're very safe and effective drugs. I think if we look at the side effect profile from this study, it aligns with other research that ketamine may have higher risk of side effects, like the agitation.
Yeah, absolutely. So 7 patients in the ketamine group actually required midazolam due to acute behavioral disturbances from carry. So that's one of the outcomes they were looking at was like midazolam administration. So the patients that received ketamine, some of them actually needed that, but then also some patients that received morphine needed naloxone. So these are just balancing the medications, right? It's for what the cases are.
That's fine. It's always a balance of probabilities.
Yeah.
Medicine's hard.
Yeah.
Right? It's hard. And just think if, okay, I give some ketamine and they're having agitation and I have to give midazolam. It's like I'm already giving another medication on another medication. The more medications we have can increase the side effect.
Yeah, especially with, like you said, the elderly population, then you're just stacking a lot of things against them, right? So I think I agree with you. You take it step by step. Probably start with that gold standard opioid medication, which is probably going to be fentanyl in these acute, severe trauma patients for us. And then, use that as second line, unless your patient is hemodynamically very much unstable. You're extricating them. Maybe you need something very fast on that'll effectively, treat their pain while maximizing the hemodynamics. Then I think ketamine is an amazing option. But I think as paramedics use these medications and get used to them, I think that's where we're going to start seeing more independent thought and practice around this, which is great. People will be able to kind of develop their own practice using these medications in the way that they're comfortable. So.
Yeah. And it takes time, right? And it's new, and of course it's the shiny new toy, but we have to respect it. And I like that you said the operational standpoint is like maybe extrication, but the key is we don't want to knock them out. That's not the intention. Like, I'm not sedating you with ketamine to take you out of the house. It's at the dosages. We're not trying to dissociate. We're giving sub-dissociative dosages to overall cause anxiety lysis. And so I just alleviate your anxiety, which is very, very mild sedation.
Yeah. I think that's a very important, positive from that medication, though. It does cause that anxiolysis. Does cause, that a little bit of like disconnect from the limbic system to the external stimulus, which is what's going to, potentially make your patient suffer less during that extrication, especially painful extrications from MVCs, right?
But let's play devil's advocate. Does morphine cause anxiety lysis?
For sure. I think the morphine does cause like more dysphoria as well, though. Patients get nauseous. Patients get like kind of upset and a little bit unhappy. Fentanyl does that. Fentanyl does have that like euphoria, a little bit more sedation effect, which is why like it's still first line and excellent medication. So.
And that's very good because the study recognized they did not treat or study fentanyl, and fentanyl is a very good analgesic medication. And let's go back to the roots of this study because this is relevant too. They've studied it in this study with the IV and IO, but they didn't test intranasal or subcutaneous routes. So we can't specifically draw conclusions for our practice here in Ontario from the study looking at that or not looking?
Just anecdotally, I could imagine intranasal ketamine would be a lot more effective early on than giving like a patient sub-Q morphine when you're trying to get them out of a car and leaving a snowstorm. Just thinking about those things, right? How slow of an onset that sub-Q morphine typically is. I think that would be a very different study with very different results.
Yeah. Again, it's all contextual.
Absolutely.
Like, but I think that's brilliant. Let's say they're stuck in a car or you can't get IV access, they're in severe pain. Like the intranasal route's amazing. No sharp, it's highly vascular, gets absorbed quite quickly. I can just squirt in your nose, then we can extricate you and doesn't typically drop your blood pressure at the dosages we give. That's why they remove the blood pressure parameter for 5.4. So you can give it for trauma. Then if you want the multimodal approach, ketamine could be added on top of that if it's specific, indicated and everything, maybe increase your blood pressure.
Yeah.
So very interesting drugs.
Absolutely. Yeah. I guess that's a good take home for this, you know? We'll start using it more and see what happens.
Well, the common question that we always get, it's when do I know when to integrate ketamine as that multimodal approach? And honestly, it's like, can't tell you. That all depends, which is not a good answer, but it's the best answer because it all depends on the patient, how they're responding, what's the pathology, what's their vital signs, what's the risk.
And I think exactly what you're saying now represents a really amazing paradigm shift in paramedicine, which is here's all these options that you get, and I'm not going to prescribe you a super rigid algorithm for when to use what. You know, you can look at your patient, you can read the literature, do your study, and decide when you want to get his medication, contextually and through experience. So I love that.
100%. And I guess talking to the physicians, everyone has a different perspective, but if you're going to try an opiate first, make sure you give an optimal dose to see how they respond before maybe moving on to something else. But imagine you had somebody like multi-system trauma, like broken pelvis, broken fevers, hypotensive. I'd probably move to fentanyl and ketamine a lot quicker than somebody that just broke their own. That's vitally stable, like very different circumstances.
100%.
So this is not medical advice. It's just kind of looking at this paper and thinking about these different scenarios and applying it all to the context.
So with ketamine, like why does it cause these acute behavioral disturbances that we're worried about to a degree with its use in our patients?
So let's look at how it works mechanistically. So it's NMDA receptor antagonist, N-methyl-D aspartate receptor antagonist. No one cares about that, but that's what it stands for. So those are abundant throughout our brain or spinal cord, which involved in pain transmission, right? How we sensitize to it, but at very minor, trivial amounts. I shouldn't say trivial, very trace amounts in comparison to the NMDA receptor antagonism. It can bind to mu opiate receptors, which is the agonistic action. So that's where you get the sedative effects, kind of this very mild sedative effects. So we know mu opiate receptors are heavily involved in pain modulation and that euphoria. So that's how it works. At the dosages we give, typically won't affect their cognition. And again, it doesn't cause that dissociation, but some specific subsets of the population may be more prone to it. And especially at higher dosages, or you have other drugs on board or whatever other medications you're on, or you have a genetic predisposition, maybe you have this kind of agitation. It happens in people. It can happen in the elderly. It can happen in children. How, like at the analgesic dosages, is it common? Say no, but it can happen. Will happen, right? And that's because of this, what do they call it? The emergence phenomenon. Unlikely to occur at our dosages, especially if we slow push it. That's the recommendation, that you give it slow push over 2 to 3 minutes to mitigate any side effects for that reason, or put it in a 50 cc bag and infuse it. Like that's probably the best way, but some services don't have capabilities, right? So there is a direct correlation between higher dosages and how fast you administer it with the side effects. So it's a very nuanced thing, because we think about, I have to know when to give this medication, when it's beneficial, what's the risk and benefits, but also how should I give it? And how should I administer and draw it up? Like it's a lot of cognitive load on these busy calls, right?
Yeah.
So I know some people like prone or history of schizophrenia have higher risk of experiencing self-delirium, especially at the higher dosages. Because if you look at like, what does that mean to dissociate? Basically means if I give high dosages of ketamine, I rip your higher executive function away from your brain. So it's like you're just a brain stem that's pumping. That's why it generally keeps their airway open, keeps them breathing, keeps their circulatory system intact. So you're just a brain stem that's there. But your body or your soul's dancing with naked elves somewhere else, right? So but the problem with that is, what if I take you from the dissociation state and bring you back to this world and you come back severely agitated? Because you can't associate what's real and what's not. You'd be agitated. And that's why in hospital settings, especially peds, when they wake you up, you're in a nice, calm room. Lights are dimmed. No one's yelling at you. No one's wearing yellow uniform saying, hey, hello to everything. You'd be agitated waking up to that. Yeah. So it's all context too of your settings. So that's kind of the history behind it all.
I think that's really good and operationally that tells us, what to expect with this medication, especially if you do reach those dissociative states and how to, optimize your environment or prepare for those possible adverse outcomes, right? Like you said, extremely rare, but still very good to be aware of.
It will happen.
Yeah.
And again, talking to the physicians that seen it, they're like, ooh, that's not really like the hypersalivation, this increase in saliva production. They're like, ooh, that's not good. But everyone else, oh, do I patch atropine and give glycopyrrolate for that? And this is like, no, section. Don't forget, we can use a yanker.
The basics, right? Always.
It is rare in laryngospasm. So if they talk about the Larson's maneuver, where you put your hands on the Larson's notch there, hopefully should alleviate it. I don't know how long.
My understanding is that's much more high risk for your intubating doses, right? Anyways, so I don't think, like you said, it's going to be very rare.
Very rare. And it can lead to transient apnea, especially in children, the elderly. And it's usually self-limiting, but again, that's still pretty significant consequence. And we have to maintain ABCs because we have to remember, just because it genetically preserves their ABCs doesn't mean we just walk away from their ABCs. It's like, okay, I have to monitor this very intently, specifically, and put the capnography on. Watch for everything, right? Watch their blood pressure, because again, it could increase their blood pressure. So what if their blood pressure is 150 on 90, now rolled up to 200 on 110? Oops. It cannot.
And that's something to definitely keep in mind when you're giving patients, for patients with head injuries and things like that.
That one's interesting because here we have to look this up. Theoretically, it can increase ICP, but I don't think there evidence is proven that it does.
Oh, okay.
Definitively.
Yeah.
Mechanistically, it makes sense. If I have a head injury and my blood pressure is 170 on 100, I pop it up for 210 on 120. It's like, that's not good. So they're theoretically increases ICP. We don't have substantial evidence to say definitively it does.
Okay. See, that's something that I assumed because I remember all the, an intubation kind of protocols for patients with ICP, because stay away from ketamine if you're going to give a medication that's like that. They trend towards etomidate or very high doses of fentanyl, things like that. So maybe that might not be as evidence based as we may think.
The systematic reviews are okay. It doesn't mean give ketamine for head injuries, right?
No.
It's all in the context of the patient.
Totally. And if we bottom out their blood pressure, we're not doing them any service for their cerebral perfusion either. So totally.
So and that's another point. It's like, okay, if I drop your blood pressure, we know any episodes of hypertension and head injuries is horrible. Yeah, horrible. So this is why medicine's hard, right? Yeah, you can just see physicians and whomever thinking about all these consequences before they do it.
Yeah,
and that's a hard thing to do.
Yeah, and paramedics now. So yeah, exactly.
Thank you very much for watching. Please leave any comments or suggestions in our email or comments below. We'd like to remind everyone, respectfully, this is separate from our professional roles and responsibilities. This is all just educational and supplemental knowledge. Please follow local medical directives, protocols, and guidance from where you work.